no intention for copyright infringement. An overall review of my presentation today will include an introduction, an overview of the anatomy of the parotid gland. We'll be going through some of the causes, complications, and then discussing case presentations with a short literature review and an overall management of how to manage this type of case. So there has been a reported increase of fungal infections in recent decades, postulated to be due to a variety of factors, including the HIV/AIDS epidemic, advanced average life expectancy, overuse of broad-spectrum antibiotics, emerging immunosuppressive agents, and greater longevity in patients with comorbidities. Candida species are part of the normal human microbiome as commensals inhabiting multiple sites of the human body, including the oral cavity, where Candida albicans is accepted to be the most prevalent pathogen causing mucosal and systemic mycotic infections. Fungal infections remain an exceedingly rare cause of parotitis, and even more rarely a sequela of this abscess formation of the parotid gland. Historically, Candida albicans was thought to be the most common cause of mycotic parotitis. However, more recently, the once suspected benign oral commensal, Candida glabrata, appears to be a more commonly implicated pathogen. I will be reporting our experience at managing 2 rare cases of fungal parotid abscesses caused by these pathogens. The parotid gland is one of the major paired salivary glands situated preauricularly anterior to the external auditory canal, below the zygomatic arch and above the angle of the mandible. There are multiple intra- and periparotid lymph nodes which are found within this exocrine gland, which drain specific subsites of the head and neck. Stenson's duct, the duct of the parotid gland, arises from the anterior border of the gland predisposing risk factors that have been identified for fungal parotitis, including advanced age, immunosuppression, dehydration, poor oral hygiene, and comorbidities, which include diabetes and HIV. The use of dentures, in addition to this, has been reported as a predisposing factor, as well as the overuse of antibiotics. An underlying salivary gland neoplasm should always be considered and excluded with a patient presenting with symptoms and signs of a parotid gland abscess, as there has been a case report in the literature previously of a patient presenting with a pre-existing Warthin's tumor. The most common suppurative infections of the parotid gland parenchyma in adults are of bacterial in origin, and abscess formation is uncommon. It is thought to ensue due to localized glandular destruction and suppuration incited by the offending microorganism. Recognized complications of importance include variable degrees of systemic sepsis, osteomyelitis of the mandible, deep neck space infections with the potential complication of upper airway obstruction, secondary extension into the parapharyngeal space, and rarely facial nerve palsy due to the anatomical proximity of the facial nerve. A 58-year-old gentleman presented in decompensated left ventricular failure, in addition to having a 6-month history of pain in the right temporomandibular joint with a fluctuant mass, which was clinically palpable in the preauricular area. It was associated with painful mastication and a decrease in appetite. He had multiple comorbidities, including hypertension, which was complicated by target organ damage in the form of stage 3 chronic kidney disease, and ischemic heart failure, complicated by congestive cardiac failure. He additionally was HIV infected with a CD4 count of 323 and a viral load that was lower than detectable. He was admitted for the medical management for his cardiac failure and was started on oral clindamycin empirically, awaiting microscopy, sensitivity, and culture of the preauricular abscess, which was aspirated in the emergency unit. The first abscess aspirate cultured a light growth of Candida glabrata, which was sensitive to amphotericin B. No bacterial pathogen was yielded in the culture, and Mycobacterium tuberculosis was not detected in the specimen. The fine needle aspiration cytology of the mass documented the presence of acid fluorescent bacilli along with the degenerate inflammatory cells in a necrotic background. He was started on empiric TB treatment based on these FNA findings. However, there was no actual confirmed diagnosis of TB on culture. On discussion with microbiology, the concern was that there was a light growth of Candida glabrata, which may have only been contaminated from this antibiotic prior to referral to ENT. He was subsequently referred to ENT on day 8 of admission. On examination, a tender, well-localized cystic swelling over the right parotid gland was present. There was extensive oral candidiasis in the oral cavity. His facial nerve was intact, and there was no trismus and no odontogenic sepsis. Oral fluconazole and oral nystatin were commenced to treat the extensive oral candidiasis whilst awaiting cultures of the aspirate. A second aspirate was done with 7 mL of pus aspirated, which was also sent off for MCNS. And this second aspirate yielded a moderate growth of Candida glabrata, again, which was only documented as being sensitive to amphotericin B. On consultation with the Department of Infectious Diseases, it was recommended that treatment with fluconazole, 200 milligrams daily, would be sufficient to treat his extensive oral candidiasis. However, the specimens that cultured Candida glabrata were only documented as sensitive to amphotericin B. A clinical review and repeat aspiration was done on day 13 and only yielded 2 mL of pus, with no further aspiration of 25 of admission. He was transferred to a step-down facility and demised 7 days later. On the other hand, a 46-year-old female presented with multiple comorbidities, including hypertension, poorly controlled type 2 diabetes, and she was additionally HIV positive on ARV therapy. She was also diagnosed with TB meningitis and was 4 months into her anti-tuberculosis treatment. She presented to the emergency unit acutely unwell in a hyperosmolar hypoglycemic state, which was precipitated by sepsis. She was complaining of a background of a 1-week history of an index episode of a painful swelling at the left angle of the mandible. She had clinical features of acute parotitis with an associated abscess. On contrasted CT, a CT scan, it revealed a large multiloculated Rome-enhancing intraparenchymal collection of the parotid. with associated sub-centimeter reactive cervical lymphadenopathy and no evidence of pyelolithiasis as depicted on the CT images. A bacterial suppurative parotid abscess was suspected and empiric broad-spectrum antibiotics were initiated. She had an urgent incision and drainage under general anesthesia, where 30 mL of pus were drained from the collection, involving both the superficial and deep lobes of the parotid gland. Specimens were again sent off for MCNS and were cultured, and Candida albicans was cultured, which was sensitive to fluconazole. Histology from the abscess wall and parotid gland revealed a moderate acute on chronic inflammation with no evidence of malignancy or granulomatous inflammation. Following consultation with infectious diseases on day 6 of admission, antifungal therapy was initiated and was continued for 1 month. In this instance, it was 400 milligrams daily per os. She responded well to the therapy and was discharged on day 14 with a small residual granulating sinus at the site of the previous incision and drainage. At 2 months follow-up, she had complete resolution of the sinus and her surgical wound had healed with minimal scarring. Despite Candida species being a common commensal of the oral cavity, fungal infections are an exceedingly rare cause of parotitis and an even rarer cause of abscess formation of the parotid gland. There are only 11 previous case reports in the literature, and of these cases, 6 cases of fungal parotitis were caused by Candida glabrata, and 4 of these cases were caused by Candida albicans. Of the aforementioned case reports described in the literature, only 9 of these cases presented or were complicated with a parotid gland abscess. And of the 9 cases identified with parotid gland abscess formation, 6 of these cases were due to Candida glabrata, and 3 of these cases were due to Candida albicans. There are currently no formal guidelines for the medical management of fungal abscesses, specifically relating to the head and neck region. The Infectious Diseases Society of America has guidelines for the treatment of oropharyngeal candidiasis, as well as many other forms of candidiasis. And soft tissue infections recommends incision and drainage as a source control for abscesses with appropriate gram, stain, and cultures of the source. Candida albicans was thought to be the most common cause of mycotic parotitis. However, Candida glabrata appears to be more commonly implicated. A review of the literature shows, of the previous case reports, shows that treatment with fluconazole for Candida parotitis shows a 78% successful treatment rate. Dosages and duration vary or were not specified in the literature. Of these 3 cases described, oral fluconazole was administered with successful treatment outcomes of 400 milligrams daily. The management guidelines include timeous initiation of targeted antifungal therapy as well as a high index of suspicion. Surgical approach to a fungal parotid abscess should, however, be graduated. Source control via incision and drainage is only necessary when indicated, and ultrasound-guided serial aspirations can be done in an acute setting if the patient is not acutely unwell. Culture and sensitivity to direct antifungal therapy is of utmost importance. Open surgery is not without risk, as it may commit a medically fragile patient to general anesthetic and may further be complicated by facial nerve injury or wound complications, including a cosmetically undesirable outcome. Both of the cases we describe were initially treated with broad-spectrum antibiotics awaiting MCNS. Case 1 showed an improvement in clinical outcome with repeat aspirations of the parotid gland, even prior to the use of oral fluconazole. Case 2 was more acutely septic, therefore requiring a more urgent incision and drainage in theatre. Thereafter, the patient was treated with culture-directed antifungal therapy. These two cases depict the importance of primary management of a fungal parotid abscess via surgical source control and thereafter culture-directed antifungal therapy to avoid resistance. In conclusion, mycotic infections should always be considered as part of the differential in any patient, especially an immunocompromised patient presenting with a parotid gland abscess. Aspirates should be sent for bacterial, TB, and mycotic MCNS. Source control remains of utmost importance as depicted in both of these cases, and an approach to management of an abscess goes according to the clinical condition of the patient. Our approach was to manage parotid abscesses in two different ways as determined by the general clinical condition of the patients, and they both had acceptable and clinical successful outcomes. Serial aspiration can be considered as first-line therapy. However, progression to incision and drainage will always be considered in order to obtain source control in complicated infections. Thank you. And these are my references.
Any comments?
No, nice presentation.
Yeah, we
don't often. I think we generally routinely ask for fungal, isn't it? Whenever we send anything or we include fungal, simply because it's not something we want to miss.
No. Kenneth, have you seen this in Ghana at all? The Baidu? Have you seen this in Ghana? There's no comment, yeah.
It's still muted.
Agata, thank you very much. I haven't got much to add there, other than, as you say, we must make sure that we send these specimens for the correct cultures. I wouldn't normally send for fungal, but now I will.
Yeah.
Would you have done that in cleaning?
Yeah, we do, but basically because it's covered, I think we've just, working in this hospital, we've seen all sorts of very wonderful things. And it's just an opportunity, if you're going to, especially if you're taking the patient to theatre, because theatre time is quite precious.
Yes.
And it's just easier to just ask one time, just to exclude. So I think that first lady, Agata, sorry, the second, the lady, the second lady, I think what threw us off there is that they said it was just was it mixed growth initially? So the first, we were thrown off course with that lady initially, weren't we?
From what I remember, we were suspecting a subject with bacterial parotitis,
Yes.
which was overwhelmingly septic. The other differential was the lymphoma, and then we did suspect, we did also culture fungus. We weren't sure whether it was a
Yes.
or
Or whether it was yeah, exactly.
I think one of the problems with the fungal infections is often, it takes a while to culture the organism, so often you have to go on the ground steady.
Yeah. Yeah.
So both of the cases were treated initially with antibiotics targeting sort of bacterial picture, but once the fungal
Yeah.
were out.
So it's, I mean, it's just, it's not the first time we sometimes the culture, or it says fungal elements, but we're not sure whether it's the offending organism or whether it's just a contaminant. It's happened to me in the ear as well, with an necrotizing otitis externa. That you culture you sort of grow fungus, and then they go, well, we're not sure if this is the organism or if. And so it can be quite tricky to diagnose a systemic fungal infection. Yeah. Can I just ask, in the literature?
Yeah, so what's also quite interesting is that, in the guide, that it was to amphotericin B, but that's not recommended on any of the guidelines. And
Yes. Can I just
sorry,
ask? Agata, in the literature, so both of these patients had fungus elsewhere. I mean, the other patient had extensive oral candidiasis, and this lady, if I remember correctly,
also
had, yeah, she also, so in those other cases, did they have evidence of candidiasis elsewhere, or was some of them only the parotid?
only the parotid is described. Well, they focus only on the parotid. I mean, I could go back and review the literature again, but I don't recall oral candidiasis as being something overtly mentioned in the previous case reports.
Yeah, okay.
Shavina's asking, if the patient presented with a facial nerve palsy, would you continue sterile aspirations or take to theatre for formal incision and drainage?
I don't think it makes a difference. It's a family condition.
Yeah.
So I don't think I would manage it.
No, I don't think so either, yeah.
You can also use inflammatory markers in clinical judgment. The patient is improving clinically. If you take them based on facial hypocalcium.
Yeah.
He says, good morning all.
Janet, have you seen any cases of fungal parotitis?
I have not seen fungal parotitis, but manage a few bacterial.
Okay, all right. Yeah. They're not unusual. Okay.
Most of our patients are diabetic.
Because this would be a nice case to present to the African Head and Neck Society meeting. It's a nice thing. So if you you don't work, you might as well get maximum mileage out of it. And so if you'd like.
Yes, sure, Prof, that would be great. Thank you.
Okay, I'll send you the contact details of the meeting this Friday.
Yes, Prof.
At 6. So if you haven't got enough cases, that might be a good one to do if you'd like to.
Okay, great. Thanks.
Thank you very much. Very nice presentation.
Thank you. Thanks, everyone.
Okay.